after 8. We are delighted today to have Dr. Shri Sharma from Arcana Labs in Little Rock with us. Dr. Sharma is a nephropathologist from Little Rock, Arkansas, from Arcana Labs. He did his training from AIMS, Delhi, and then did residency in pathology in US, as well as a fellowship in nephropathology from Columbia. He has been at Little Rock Arcana, at the Arcana Labs, where he directs the nephropathology lab. He's a passionate teacher. He has got many teaching awards, and I've heard him speak today. Speak on AKI before. It's a wonderful teacher. And I think today's talk is going to be interesting because he's going to go through some live slides, as we shall see shortly. Welcome, Dr. Sharma.
Thanks a lot, Swapnil, and thanks a lot for the invitation. So I'm going to present today acute kidney injury. We'll keep the session very informal. By that, I mean, I'm not going to show you a ton of PowerPoint slides today, okay? So I'm not going to start my talk with PowerPoint. I have just 2 slides. Why did I choose to have this format? Because now, literature-wise, there is a ton of literature. We are all on social media. We get plenty of stuff to read. So I wanted to keep this talk very practical and relevant for day-to-day practices. So the cases which I have chosen are day-to-day cases. They are not rare cases. And I want you to think through those cases as a nephrologist. I want you to do, whenever you see a case, I want you to think, what are the questions you want to ask? What is going on with your patient? How are you going to talk to your pathologist? And I will show you basically the thought process of a pathologist when they go through a case. I'm not going to give you an answer on every slide right away. I want you to show the struggle which I go through when I go through a case, the problems which I face in a day-to-day life. And because that discussion, that thought process is important for us to treat a patient, because most of the cases in day-to-day life might not be straightforward, but we are so accustomed of thinking in terms of well-defined diagnostic categories. When we think about AIN, we think about a particular morphology in our mind, and we think all the cases are going to have that morphology. That is not right. Similarly, when we think about like ATN or anything, we think of 1 or 2 particular morphological pictures in our mind, and we think all the cases are going to fall in that category. While in real life, 2 cases of AIN might not look the same. They might be totally different, but still we end up making that common diagnosis. So I wanted to show you that diversification today. So I will start with biopsy slides. I will let you know how to approach a slide. Then I will show you the morphological spectrums of acute kidney injury. And in between, I will also tell you what are the use and limitations of kidney biopsy, because that is very important for you when you make a decision on treating your patients. So why kidney injury? Because diagnostic markers of AKI measures loss of function, not injury. When you do a biopsy, because whenever you are suspecting a parenchymal injury, only then you are doing a biopsy. So all the cases which we are going to see today are going to have parenchymal injury, because that's why you biopsied it. And that is what I'm going to show you today. History. Whenever you examine a kidney pathology, there are a few things which are very important. Clinical history is very important because context is very important. When you look at the kidney biopsy, light microscopy, IF, and EM, all 3 modalities are important. To make our session very simple, this is going to be the history for all of our cases today. So I'm going to make life very simple. And anyways, you want your pathologist to know everything, right? Because many times I hear, hey, I want my pathologist to make an independent diagnosis of the clinical history and then discuss those cases. So let's keep it very simple and let's jump to real cases. So before I start, I wanted to give like a 1-minute overview of a normal. So whenever you see a kidney biopsy, you would like to know you are within the cortex or medulla. So this is medulla without glomerulus. This is the cortex. In low power, you can see the glomeruli. You can see the tubules are back to back, and there is nothing in between the tubules. There is nothing in the interstitium. Tubules look beautiful. There is nothing within the glom. The gloms are not hypercellular, no necrosis, no crescents. And you can see the tubules. They are beautiful. They are back to back. And this is a PA stain, because this is a pink, so I'm not going to go over the stains and basic. H&E is pink, PAS is more pink, and you can see the basement membranes nicely, and you can see the peritubular capillaries, you can see the tubules, there is no inflammation. Okay, when you go on high power, you can see the brush borders beautifully. So everything which I said is normal. So now onwards, let's see what is abnormal. What are the different things which you can see in AKI. So as soon as you see this biopsy, you know the tubules are not back to back. In the last case, you saw the tubules were back to back, but in this case, tubules are separated from each other. There is a some space. The tubules are of different sizes. They are of different shapes. And you can see the epithelium, which was nice and more of cytoplasm in the last case, is not there. The lining epithelium is simplified. That is how you define acute tubular injury. Luminal ectasia, simplification of the lining epithelium, loss of luminal brush border. That's it. So if I see a case of acute tubular injury, I cannot give you an etiology in many cases. So I will give you a broad sense that, oh, there are differential diagnosis includes ischemic and toxic forms of tubular injury, and boom, my job is done. So our job as a clinicians are to try to find out the etiology. We will try to find out the etiology, okay? So in this case, we don't see much within the tubules. They're all empty. There are few tubules which are filled up with some pigmented cast. So they can be anything. So when these tubules get damaged, the lining epithelium will be sloughed off. It will go back within the tubules. You can see that. Your patient might have hemolysis. Your patient might have rhabdomyolysis. Your patient might have light chain cast nephropathy. You can see a bunch of things within the tubules. So you have to make sure you get the clinical history, you get the IF done, and that is how you will make the diagnosis. In this case, you don't see a lot. Most of the tubules are empty, and you still see a lot of interstitial edema. And you don't see a lot of interstitial inflammation, basically. The interstitium is relatively clean besides edema. So you browse through the kidney. And the other thing is that the acute tubular injury can be variable in morphology. Like this field looks totally different than the last field. You see a lot of prominent vacuolization within the proximal tubules, you know? And when you go elsewhere, you don't see that much of inflammation. So basically, this is acute tubular injury. That's it. So what are the problems which you will find commonly when you make a diagnosis of acute tubular injury? One of the problems I have commonly seen is making or assessing IFTA, assessing tubular atrophy and interstitial fibrosis. Many times we believe anything which looks blue on trichrome is fibrosis. But in acute tubular injury, edema is also going to look blue to you. So you have to be cautious when you make an assessment of fibrosis in a cases of acute tubular injury. The problem is specifically going to be really bad for you if you're looking at a case of acute tubular injury in a background of CKD. Because your patient is already having chronic kidney disease, there will be already scarring, and your patient develops the acute kidney injury or acute tubular injury on top of that. So assessing fibrosis is going to be really tricky in those cases. That is where conversation is going to happen between you and me. I will tell you, hey, I see acute tubular injury. There is a lot of interstitial edema, but unfortunately, there is a lot of underlying fibrosis also. I'm really having a hard time in assessing the fibrosis. But I will give you my estimate, but don't go just by that, because that might not be a truly representative estimate. So that is where our conversations are going to help. Okay. So I mentioned the role of immunofluorescence in acute tubular injury, and different kinds of cast which you can see in acute tubular injury, and the importance of clinical history and immunofluorescence. I know there are a lot of fellows in the audience. Can you give me an example of acute tubular injury? This is a case of acute tubular injury where you cannot make a diagnosis just by light and IF. You will need EM to make that diagnosis. And the only history which you got was the history which I gave you. I might end up changing the history, say 80-year-old male presents for evaluation of acute kidney injury, and this is the light microscopy finding. IF is negative. Can you tell me a reason or an etiology where I need an EM to make the diagnosis in AKI? So I don't see any answers in the chat. Swapnil, if you get any answers, let me know. But the answer, just for the sake of time, I'm going to tell you minimal change disease. 20 to 25% of the patients with minimal change disease sometimes can present with AKI. So if you see a plain AKI in an elderly, definitely make sure you rule out minimal change disease. So there are cases of AKI where you will need EM. So this is AKI, just looks like the other case which I had shown you with a lot of simplification of the tubules, but this case was a minimal change disease. And for the fellows, I wanted to show you something like in exams frequently, specifically in transplant, you end up getting a question on acute tacrolimus toxicity with cytoplasmic vacuolization. This is how it is going to look like. In native scenarios, you are going to get cytoplasmic vacuolization because of many, many causes, contrast, osmotic agents. It's not very specific. But in transplant, for exam purposes, if you end up getting a question, most likely the question is trying to ask you about TAC toxicity. Okay, so let's move on to different cases. So how this case is different from the others. In the last case, we ended up seeing the interstitium was relatively clean. In this case, you see a lot of inflammation in the interstitium. So from our knowledge, we know that there are two main causes of acute kidney injury: acute tubular injury itself and AIN. So whenever you start seeing inflammation within the interstitium, you are thinking about acute interstitial nephritis. Okay, so think about acute interstitial nephritis. But how do you make a diagnosis of acute interstitial nephritis? Feel free to use the chat window. Okay, I'm not interacting with you a lot today because this is grand round. Otherwise, I would have not moved forward without those answers, you know. So acute interstitial nephritis, we say something as AIN when we see a lot of inflammation in the interstitium, but that is not enough. You have to see tubulitis. That means the inflammation needs to go cross the boundary and cause tubulitis. Only then you will call something as interstitial nephritis. Like in this field, you can see the lymphocyte has crossed the tubular boundary, the basement membrane, and it's causing tubulitis. That is important for you to call something as interstitial nephritis. Because interstitial inflammation, you can see just interstitial inflammation, even in the case of ATN, acute tubular injury. Because what is going to happen, just because of the tubular injury, basement membrane might end up rupturing, the tubular contents are going to come out, inflammation is going to come as a response to that. You need to see tubulitis to call something as AIN. And classically in books, you must have read the inflammatory infiltrate can be of various nature, like by different types of leukocytes. You can see lymphoid cells, you can see plasma cells, you can see eosinophils, and the way you recognize eosinophils is by red cytoplasm. In this field, you can see plasma cells by eccentric nuclei with amphiphilic cytoplasm. I'll show you different cases where you will be able to identify all the different cells. So basically, this is acute interstitial nephritis because you see inflammation, you see tubulitis. Again, you need to go back to the clinical history to find out the cause of AIN. I won't be able to help you out in that to find out the etiology. But if I do that on every case, you will get frustrated with me. You will say that if I have to do all the entire job, you are just going to tell me acute interstitial nephritis. Why do I need you, kind of a thing? So that is where the discussion will start. You and I need to talk, okay? So what are we going to talk about? So I'm looking at this case, and in my mind, I'm looking at the morphology of the cells. Okay, I see lymphoid cells, I see eosinophils. What else do I see? Focally, there are some neutrophils. There are some neutrophils which are causing tubulitis. There are some lymphocytes which are there. I'm very confused. This looks like a mundane acute interstitial nephritis. There is some cellular debris around it, but I'm not able to come up with a specific etiology. So you and I are talking. These days, immune checkpoint inhibitors are also a very common cause of acute interstitial nephritis. So you and I will talk, and you will tell me the patient is on immune checkpoint inhibitors, and I will tell you most likely that is what's going on. Because you can see focal neutrophils and neutrophilic tubulitis, which you normally see in pyelo even with immune checkpoint inhibitors. So this case, if you don't give me that history, I might end up raising a possibility of UTI. But if you give me that history, I will say, hey, this falls within that spectrum. In immune checkpoint inhibitors, I have seen focally prominent neutrophils and have seen neutrophils within the interstitium. So that is how you and I can come up with a specific diagnosis just by talking. But sometimes you are busy. You're not able to pick up the phone, okay? So is it possible for me to come up with a specific diagnosis on my own without talking to you? It depends on case, right? So if you give me a biopsy which looks like it, I don't need to talk to you. For me, the biopsy, out of the top three differentials, most likely I have only one differential in this one: infection, infection, and infection. Even if I don't talk to you, most likely this is a pyelo. So in a pyelo, you will see a flooded neutrophilic tubulitis, a lot of tubules which are just going to be filled with neutrophils. So in a transplant setting, it is very easy, pyelo, but in native scenario also, you can see pyelonephritis. So whenever you see a biopsy which has a prominent neutrophils, you make a diagnosis of pyelonephritis. So I will let you see that for a while because you might end up seeing this in the exam. So see so many neutrophils, and the way you recognize neutrophils is by that polylobated nuclei. Can you see that? All the cells which you see in the field, they don't have single nuclei. They are all polylobated. And this is a very good field to have. Just keep this picture in your mind for pyelo. So a lot of neutrophils in the interstitium, a lot of neutrophilic tubulitis, and you see a lot of neutrophils within the tubules, also like a neutrophilic cast. So this is a good, very good example of a pyelo. I will show you the same fields on different stains, so you can keep that picture in your mind. And see, this is a PAS stain, and how beautiful that stain is. You can see the cuffing of the tubules by neutrophils. You can see neutrophilic tubulitis, and this is entire interstitium is edematous. I'll show you the same thing on the Jones. Jones stain, black. Silver stain is always black. You can see the basement membranes are black. That is how you're going to identify that. And you can see the neutrophils. And let me show you the trichrome stain also on this one. The same thing on the trichrome. Trichrome blue stain, and you can see the cuffing of the tubules, same field on a trichrome stain. So this is a very good case of pyelo. And this is again a very good example of interstitial edema. Can you see how badly the tubules are separated from each other just because of the interstitial inflammatory infiltrate? There's a lot of edema. When this biopsy is going to heal, how are you going to estimate how much residual fibrosis is going to be there? At this stage, you cannot. At this stage, it is all acute. Once you will start treating the patient, biopsy is going to start undergoing scarring. So after the completion of the treatment, whatever is the baseline creatinine, that is going to be the residual kidney function. Because at this stage, it is not possible for me to say how much residual fibrosis is going to persist, because that is going to depend how the kidney is going to heal, basically, and how soon we start treatment. That's why it is very important to make a diagnosis of interstitial nephritis very fast, because the extent of scarring is dependent on the time frame. When do you start the treatment? So that's why the biopsy can be very, very helpful in acute cases, specifically when you are seeing acute interstitial nephritis. Sometimes you end up having medulla only. Okay, so you all have a good team, so you might not end up seeing a lot of medulla in your practice, but sometimes we end up seeing a lot of medulla. So most of the time in native scenario, there are only few disease conditions where I can give you like a diagnosis on a medulla, but most of the time I cannot give you any diagnosis on the medulla. This is the exception, where a medulla was sampled and I see almost a similar thing, a lot of neutrophils and neutrophilic tubulitis. Same thing which we saw within the cortex. So if I see that within the medulla, I can tell you are dealing with a pyelo. And most likely this is an ascending infection, because medulla also is so badly involved with neutrophils, and same morphology which we had seen last time, but this morphology is confined to medulla. So you can say this is an ascending infection, it is coming, and that's why medulla is involved. So even in this case, no cortex is present, I can give you a specific diagnosis. Okay, makes sense? So we saw just mundane acute interstitial nephritis, acute tubular injury. We saw immune checkpoint inhibitors. We saw pyelo. So is there anything else which we can do with just mundane acute interstitial nephritis? Can you tell me something more than that? So in this case, you see a lot of plasma cells. Can you identify that? Everything is single cell nuclei, a lot of amphiphilic cytoplasm. So basically, in this case of interstitial nephritis, you are seeing a lot of plasma cells. So when you see a lot of plasma cells in a transplant setting, obviously you think of rejection, but you also think of viruses. In a native scenario, when you see a lot of plasma cells, I want you to think through very fast. What are the things which are going on in your mind when you see a lot of plasma cells in the interstitium? Interstitial nephritis for sure. And there are a lot of plasma cells. So you are thinking about the etiologies. So again, normal etiologies will be there, like all the etiologies which we discussed on the acute interstitial nephritis will be there. But when you end up seeing a lot of plasma cells on the biopsy, one of your differentials is autoimmune disease in a native scenario. The other differential which goes to your mind is IgG4 related disease, because you have a lot of IgG4 positive plasma cells in IgG4 disease. So you will end up doing a staining for IgG4. So in this case, I ended up doing a staining for IgG4, and we ended up finding a lot of plasma cells. These are all IgG4 positive plasma cells, and you see more than 50 of them in this high power field. So you know you are dealing with an IgG4 related disease. So in this case, again, IF will be important, because in IgG4 related disease, you will see TBM deposits depending on how extensive your disease is. You might end up seeing a membranous nephropathy also, because in IgG4, you will see membranous also. Not always, but sometimes. So you saw the nature of the infiltrate can help you determine the etiology of a disease sometimes, not always. So that's why when you look at a case of acute interstitial nephritis, you pay attention to the type of interstitial inflammatory infiltrate. More eosinophils allergic, more plasma cells autoimmune IgG4, more neutrophils, you think about infection. Okay. Am I missing anything in interstitial nephritis category? Do you think I ended up covering the spectrum? This is all what you see normally. Anyone in the audience? Can you make a diagnosis on this one? This is again another case of interstitial nephritis, AKI, patient presented with AKI. What else is going on in your mind? Because I have shown you a lot of things. So can you recognize this is a very good field? You should be able to recognize the morphology. Any fellows? Give me the etiology. I showed you a good feel. So I might not have to give you anything else. This is again a good feel. Any diagnosis so far? I hear something. So did anyone make the diagnosis?
Yeah, there's a granuloma is a guess.
Perfect. Is that a pathologist in the audience?
And sarcoidosis. No, this is not from a pathologist. It's from a nephrologist.
Perfect. I am so impressed. Yes, great job. This is a granuloma. So sarcoidosis is common, but granulomatous interstitial nephritis, the most common cause is still drugs. So when you see GIN, always think of drugs. Depending, again, the context is important. If you already know your patient was showing features of sarcoidosis, think about that. But most common cause of granulomatous interstitial nephritis generally is drugs. Okay. And then in some part of the world, it might be tuberculosis also. In this part of the world, we don't think about tuberculosis as the first differential unless your patient is immunocompromised. If your patient is immunocompromised, you will think about mycobacterial infections. You will also think about fungal infections, because you can see granulomatous interstitial nephritis also in fungal infections. But these granulomas are good examples of granulomas. So yeah, you can get that as a question in exams. That's why I wanted to show you granuloma on all the stains so that you don't miss granulomas. This is a granuloma on a PAS stain. These are very good granulomas. Yeah. And silver also is very good to appreciate granulomas. This is a good stain to appreciate granulomas on a silver. So you can see granulomas on all the stains, HNE, PAS, as well as silver, but you ended up picking that up on just HNE stain. This is again a good example. Yeah. And this is a trichrome stain. You can assess the extent of fibrosis, and you can also see the granulomas, which are very well defined. So I'm going to show you one field. And can you tell me the problem normally which you face in day-to-day practice? What do I want to show? So normally when you biopsy, we always say that biopsy at least 2 cores. and the sampling bias, which happens in the biopsy. And this is a very good field for me to show you that. Why do I say that? See, this core is involved. You can see your granuloma, you can see your fibrosis, you can see the nephritis part. This core is relatively not involved. If you sample this one, I'm going to tell you this is granulomatous tubular interstitial nephritis. If you sample this core, I will say, hey, there's nothing, man. Nothing is going on. Can you see the problem of sampling bias? Pathology is good. It is a gold standard. But you have to be aware of the sampling bias. So what do I mean by sampling bias? Number, of course, because you are targeting different areas of the kidney. If the disease is focal versus diffuse, you are going to get it. Size of the core. If it is a very small core, you might end up missing a focal disease again. The number of the gloms is again as indirect representation of the size of the core. But location is also important because sometimes the diseases are very focal. So if you biopsied only one focus, you might not end up sampling a disease. That's why in a transplant, in an adequacy criteria on the BAF, you will see they say 2 cores. That is true in many cases, even in native scenarios. When we think about acute interstitial nephritis, we always think, hey, it has to be diffuse. If I have biopsied a case, if that says there is no evidence of interstitial nephritis, that has to be true. But this is a good example. If you give me this score, I'm not going to make a diagnosis of GIN or granulomatous interstitial nephritis. I will make that diagnosis only on this one. That is where you and I discussing a case is important. Because if you see a report, you end up assuming this is it. But you and I will discuss and I will go through that sampling bias with you again so that it gets refreshed. If you give me this biopsy, this score, I will say, hey, this is severe fibrosis. You will make an argument, hey, my patient's creatinine was normal just a month back. You are telling me this is a severe fibrosis? Hey, because this score is completely diseased. That's why this is showing you that much of fibrosis. In contrast, this score is not showing you that much of fibrosis. This is, again, a sampling bias. Fibrosis chronicity is a very important prognostic marker because your outcome depends on that. But it is, again, very problematic. It is very dependent on the sampling. So you and I need to talk. If it is a sampling issue, we need to talk. And I will tell you, hey, this can be a sampling bias. If you think creatinine was normal, this can be an acute disease. Treat it and see where the patient goes in. Because I don't want you to, like, GIN is an exception. You are going to treat. You are going to take a chance. But there are some kind of GNs where you will think, oh, there is severe chronicity. I'm not going to take a chance. I'm not going to treat a patient. So you should not make that judgment solely on the basis of the kidney biopsy. You have to bring in your clinical information because the extensive fibrosis which you're seeing on a biopsy can be a sampling bias. So this is a good point from this field. So I have shown you a case. Almost always I have given you a diagnosis on all the cases which I have shown. So are the pathologists that good? They can give you a diagnosis on almost all the cases. I've shown you a bunch of these cases like that. And I've said this is all acute tubular injury. I have given you an example of granulomatous interstitial nephritis, brought up the sampling bias. If you end up giving me this score, this part of the core, I will say acute tubular injury. Can you see this part of the core? If I give you this score, this part, you're going to say it is acute interstitial nephritis. Can you see the problem of sampling bias? In that example, it was easier for us to digest because the cores were totally 2 different cores. So we ended up assuming that. But I have shown you the sampling bias within the one core itself. If you give me only this sized core, I will say acute tubular injury. If you end up giving me this part of the core, I can make a diagnosis of acute interstitial nephritis. We think sometimes these diseases are so easy to diagnose, I'm not going to miss it. But even with simple diseases, sampling bias can come. So you have to be aware of that. And most of the time, as a fellow, when we think about interstitial nephritis, this is the picture which we get in our mind, like, because in the books also, a lot of eosinophils, lymphoid plasma cells, they are going to come. So this is a very good example and a very good field for acute interstitial nephritis for you. So we saw the importance of sampling and the biases, okay? So again, pyelo, we think, should not be a sampling bias, right? Because pyelo, entire kidney will be involved. This is one core of the kidney. If you give me this score, at the most, if you tell me creatinine is increased, I can say, oh, there's multiple injury which is going on, and I will sign out this case. Can you see the problem? This case had a lot of inflammation in the other core. And if you end up seeing even the medulla was involved with the inflammation, and you have neutrophils and neutrophilic tubulitis, similar to the pyelo which I had shown you. This is a case of pyelo, actually. This is an ascending infection. This, again, is a sampling problem. All the cores are not involved equally by the disease. So most of the cores are involved in this one, but this core was not involved. So if you end up giving me this score, I'm not going to make a diagnosis of pyelo or even interstitial nephritis. I will just sign out this case as acute tubular injury. Unless you end up giving me this scores, I will make a diagnosis of acute interstitial nephritis. But in this field, say neutrophils are not predominant, I'm not going to raise a possibility of pyelo. I will raise a possibility of pyelo only if the neutrophils are prominent. So even in a simple case of acute interstitial nephritis, you have to correlate with clinical features. You have to correlate with other lab features. You and I need to talk. So for kidney pathology, almost every case which might sound simple, it has to be a clinical pathological correlation. You cannot make a judgment just by one field, one slide, one piece of clinical history. And with the last few cases, I just wanted to show you that the cases which appear simple, straightforward, because initially when I was showing you cases of API, pyelo, we thought, oh, they're all classical. Boom, we can easily make a diagnosis. But the rest of the cases ended up showing you the problems of sampling. Okay. So this is very important. Fibrosis is a problem. You and I need to talk. It is very subjective and it is very contextual. Similarly, the infiltrate and sampling bias also is again very important. So let us move on and see some other cases of acute tubular injury. So this is again a case of acute tubular injury, but you see something else within the tubules. It is like a pigmented cast. So whenever you see pigmented cast, there are a few things as a fellow which should always come in your mind. Okay. You should always think of an abnormal cast like light chain cast, because light chain cast can have any morphology. Classically in the books, we will say PA is pale, giant cell reaction or cellular reaction. I'll show you those cases also. But pigmented cast, always think about that. Also think about myoglobin, hemoglobin, bile. All those things will come to your mind. Sometimes your lining epithelium will be sloughed off. It will cause very degenerated or cellular cast, but sometimes it can look pigmented. So you might not be able to tell that on morphology. So for that, you need to do stains. Like in this case, you see a lot of pigmented cast in this one. Let me show you some more fields of pigmented cast. So can you say this is myoglobin or hemoglobin? Not always, but many times we try to make a guess, so we are correct many times, like this one, which has a beaded appearance. This is good for myoglobin, but I will say that we are not 100% right. So many times we have to do stains to make that judgment. Okay. So in this case, I did a myoglobin stain and it was, let's say, it was positive. This is how a myoglobin stain positivity will look like. You saw the pigmented cast within the tubules and they are all positive for myoglobin. So now, even if you don't give me a history on this case, I can call you back and say, hey, I think your patient is having rhabdo. You might end up saying no to me that. Have you seen that? Because CPK levels go down towards the normal range very fast. So it is possible when your patient was found down, the CPK levels were elevated at that time. By the time you ended up doing a biopsy, your CPK levels are normal. But when the patient presented to the hospital, you didn't find elevated CPK levels. That's why in the biopsy, for me to make that judgment is important for you, because this patient is not going to recover like immediately, like a simple ATI. It's going to take a while. And that piece of information is important for you. Okay, and you can see the amount of pigmented cast was not looking that much on the biopsy, but this patient has a lot of pigmented cast. You can see the positivity not only within the tubules, you can see the positivity also within the cytoplasm also. And sometimes it is possible let me show you another example. If I have to sign out this case, again, you will tell me, hey, Sri, you are just boring me by showing you the repeated cases of acute tubular injury. I know this case. This is how you started. This is acute tubular injury. I don't see any pigment within the tubules. Move on to the next case. I will move on to the next case. But did you see something? This is again myoglobin. I didn't see any pigmented cast within the cytoplasm, but see myoglobin is present within the cytoplasm, and you were not able to appreciate that on the light microscopy. It is possible in cases of rhabdo, you might not be able to see pigmented cast, but you will see myoglobin degenerated within the cytoplasm. So it's good to have that suspicion going, because again, this piece of information is going to be very helpful for you, because your patient's recovery is going to be different in this case. So that's why that suspicion and that awareness is important. And a simple case of acute tubular injury, which looks like a simple case of ATI, will give you variable pieces of information. So with that, I wanted to show you another case of acute tubular injury. And now you all are good in that morphology, isn't it? So another case of acute tubular injury, simple case. Any tricks or magic? Is it going to work? No. A simple case of acute tubular injury again. So what I'm trying to show you. Another case of myoglobin? No. This is hemolysis. This is hemoglobin. So all pigmented casts, as I said earlier, are not myoglobin. This is a case of intravascular hemolysis, and it was not suspected clinically. The patient presented with AKI, hemoglobin was low, but the hemolysis workup was not started. But on the biopsy, suspicion was high, and the pigmented casts were present. We ended up doing a hemoglobin stain, and it shows hemolysis. So intravascular hemolysis, first time diagnosed on the biopsy for the patient. So I ended up showing you the magic of special stains. Okay. This is another case of acute tubular injury. Can you see that in the low part? Anything else jumps to your eyes in the low part? I wanted to show you this magic. Let me see. I can show it to you or not on online. Yes. Can you see that now? This is polarized microscopy. You can see a ton of oxalate crystals on the biopsy. This is a case of acute tubular injury where on polarized microscopy, you can see oxalate crystals. Can you see that? I'll go on high power. And I have to change the exposure because I changed that. And you can see the tubules are full of oxalate crystals. So in this case, you're seeing a lot of oxalate. And again, there are a lot of causes for intertubular oxalate, calcium oxalate nephropathy. You have to go back to your patient, and we have seen a ton of etiologies for this one: ethylene glycol, gastric bypass, patient having tea, almonds, smoothie, like bunch of etiologies you can see with oxalate. So you have to go. But can you see oxalate sometimes is very difficult for you to see on routine? Can you see these are oxalate crystals, but you cannot see them. So on the routine, when you see without having that suspicion, you might not be able to see them. So, but that's why you have to do polarized microscopy. Can you see that? I just ended up taking one of the objectives out, and you can see that. So this was oxalate, and you can see oxalate crystals on the biopsy. And that also is going to present with acute kidney injury. So we are almost on a theme that most of our kidney injuries, cases of acute kidney injuries, are driven by the content within the tubules. We are seeing abnormal cast or abnormal content within the tubules, and that is driving the tubular injury. So let me show you another thing. So in this one, this is a pink cast. This is a very pink cast, which has a fractured appearance, and it is causing tubular injury in the background. So we know from the books, and now we know from the examples of different things we have seen, that if it is an abnormal cast, it needs to be PAS pale or PAS negative. Okay. So I'll show you a cast which is not staining with PAS very well. See how pink the background is, and this cast are not staining, and there is a cellular reaction around it. So these are the PAS pale or PAS negative cast. So in this case, you are very suspicious of light chain cast nephropathy, and the only way you can make a diagnosis of light chain cast nephropathy is by IF. So you ended up confirming that your cast is positive for kappa and it is negative for lab, and that is how you will make. So all the cases of AKI, which I had shown you earlier, didn't need a lot of IF findings, but in cast nephropathy, you will need immunofluorescence. So you will see restriction of the cast by one specific light chain, and that is how you are going to make your diagnosis. Make sense? And you will see all the colors, like they will be polychromatic, as I had shown you on the images on the trichrome stain. You will see polychromasia on the trichrome stain on an abnormal cast. So we saw pigmented cast, we saw light chain cast. That was very good. Is there anything else on the acute tubular injury spectrum which we can see? Let me start again with the mundane morphology of acute tubular injury. That is what you have seen, right? Acute tubular injury, same slide, almost similar slide. I can use time and again, okay? So again, very similar acute tubular injury, but can I do my magic and give you an etiology just with that slide or just with that in that particular case? So let me use a PAS stain and ask you, what do you see different in this one? Can you see anything which is different as compared to the other cases? You don't see anything within the lumen, but can you see the cytoplasm? Cytoplasm is pale. In other cases of acute tubular injury, which I had shown you, the cytoplasm was not pale. In this case, cytoplasm is pale. In the cast nephropathy, we spoke about the paleness of the cast within the tubules. In this case, I'm talking about the paleness of the cytoplasm itself, of the proximal tubular cytoplasm. So Shri, what are you talking about? Why is the cytoplasm pale? Any diagnosis on this one? Can you tell me what's going on in this one? You can see the cytoplasm is completely pale on this one. So we knew about the light chain cast nephropathy. You see PAS pale cast. I know that is a cause of acute tubular injury, but why the cytoplasm is pale on the PAS and I just cannot see anything on the other stains? Let me go to the trichrome stain to see if we can figure out something. You might not be able to see that because I'm not sure how it is projecting, but this part of the cytoplasm looks different than the others. This part almost like looks like some crystals. Something is getting almost like crystallized within the cytoplasm. So now our curiosity is alive. So let me see if we can find out etiology for this one. To start, we need IF because IF is important. So in this case, when you did the IF, you saw the kappa is positive within the cytoplasm while lambda is negative. We did a paraffin IF and kappa was very prominent even on the paraffin and lambda was completely negative. The crystals which we were having problem to see on the other stains are very easily identified on the toluidine blue stain. And we use this stain to perform electron microscopy. So we ended up seeing a lot of crystals on toluidine blue stain, and we did electron microscopy, and we can see the crystals within the cytoplasm. So this entity is known as light chain proximal tubulopathy, and this can also present as acute kidney injury. So this is a light chain proximal tubulopathy, and you need IF to make that diagnosis on this one. Okay. So we spoke about different etiologies about AKI. Most of those diseases were involving renal parenchyma. Okay. But renal parenchyma is supplied by what? Blood vessels. So something can go wrong with the blood vessels and you might end up seeing acute kidney injury. This is an extreme example. You ended up occluding the blood supply to the kidney. That's why this part of the kidney ended up undergoing infarct. So this is a cortical infarct. And you know this is a cortical infarct because you can see the ghost structures. Basically, you can see the glands, you can see the residual of that. There might have been a proximal tubules earlier, but now everything is gone. So this is an infarct. This is again a very good example of an infarct. This field, you can see a little bit of interstitial hemorrhage. You can see the outline of the kidney structures, but you don't see it, the actual kidney. And this is the transition zone where you can see the ischemic change within the kidney. And you can see a lot of interstitial fibrosis as the kidney is responding to that infarct. You can see a lot of interstitial fibrosis have already started happening, and the tubules are separated from each other. And the glands, which are there in that fibrotic area, are started showing you ischemic change. So this is a very good example of an infarct. So AKI can happen because of vascular injury also. So this was an extreme example. But in clinical practice, the most common example which you might end up seeing is much more common than infarct. Anyone? This will be much more common than infarct. This is a blood vessel. And this picture is from our medical school days, right? We used to study in our medical school, mucointimal edema. This blueness of the intima is mucointimal edema. So you can see TMA also causing AKI, thrombotic microangiopathy presenting as AKI. So this is a blood vessel. This is extensive mucointimal edema. And you can see in this blood vessel, fragmented red cells. The red cells are very fragmented on this one. So this is a very good example of thrombotic microangiopathy. This is again a blood vessel, which is showing you fibrin and fragmented red cells. This is again a very good example of mucointimal edema. TMA clinically presents very aggressively, very fast. And in these cases, you will see the creatinine was normal, like just a month ago or something like that. But this kidney ends up getting fibrosed very fast. This is a low part example to show you if you deprive the kidney of its blood supply, because that is what the TMA is doing, because these are getting swollen up so much that the kidney is not going to get its blood. So it will undergo fibrosis very fast. So depending on how long it continues, you might end up seeing severe fibrosis in cases of TMA. So this is a silver stain which highlights the TMA beautifully. So you also saw the play of different stains in making a diagnosis of AKI. Silver stain always brings out the basement membranes, and see how nicely it brings out the red cells also. So you can easily see the TMA changes on the silver stain. And these are the same blood vessels which we had seen initially. So this is a fibrin and the fragmented red cells within that. And all the glands, see how ischemic they have become because we have deprived them of their blood supply. So most of us love glands. Most of the time we talk about GNs only. So how is it possible we are talking about AKI, but we are not talking about glands? So is there any glomerular condition which can cause AKI? Crescentic GNs, like RPGNs, they can also sometimes present with AKI because your patient has presented to the AR, you don't have not done, so they can present with AKI. So crescentic GNs are a very common example. And this is an example of a crescentic GN on an H&E stain. You can see a glomerular tuft is completely destroyed by a fibrinoid necrosis and a crescent. And you can see a lot of crescents. So you cannot make a diagnosis of crescentic GN only on light microscopy. You need to see immunofluorescence, you need to see EM. So on IF, you need to make sure this is not linear IgG, this is not anti-GBM, or it can be posse-immune, or it can be immune complex driven. It can be anything depending on the IF. So you don't classify crescentic GN on the light microscopy alone. But I wanted to show you the morphology of crescentic GN because this can be a common exam question. You might end up encountering that. And as a fellow, I have seen a lot of confusion of crescentic GN with collapse. If I show you this field, like a first-year fellow might end up getting confused with a collapsing GN. So the way you differentiate a crescent with a collapse, in a crescent, you see the GBM rupture and you see fibrin, which you don't see in a collapsing lesion. So this is the GBM rupture, and you see a lot of fibrin within this fibrinoid necrosis. So this is how you make a diagnosis of crescentic GN. So crescentic GN also can cause AKI, and this is a silver stain which will beautifully highlight the fibrin. And this is what I was talking about. This is the silver stain, and it highlights the fibrin and the crescent. Trichrome stain also brings up the fibrin very nicely, and then crescents beautifully. This is again a trichrome stain, bringing up the fibrin as a red thing, and you can see the tubules are full with red cell cast. So why this is important, this field is important. Let me just take this field and give you a snippet. So suppose if you ended up doing a biopsy and I see only tubular injury with red cell cast, it is important for me to raise a possibility of an unsampled active disease. So you as a clinician should be aware that crescent, you are not going to see this picture in all your cases. You're not going to see plenty of lumps involved by crescents in all your cases. It is possible in a biopsy of 40 glands, you can see a crescent only in one gland. It is possible. Suppose you ended up biopsying 39 glands, not the 40th one. You might not end up seeing that crescent. That is where the sampling bias is there. So you might end up seeing a case of acute tubular injury with a red cell cast without any crescent, while in reality, you're dealing with a crescentic GN. So always be aware. So when we are in the teaching mode, we are in the class mode or learning mode, most of the time, we think this is how it is going to be in the real life. But in real life, it is a different combinations always of diseases. You have to bring different concepts together, okay? Are you all with me on this one? You are all experts, but we are just having like 10 minutes away. So I think we have done a good job of going over the spectrum of kidney diseases, acute interstitial nephritis, and all that. So this image, I want a diagnosis from nephrology fellows. Give me a diagnosis on this one. And be sure about it, because we have spoken about sampling biases and all that. So tell me at least your diagnosis and an approach in the chat box. I'm just going through this. So basically, to help you out and to save time, I'm going to say, okay, when you look at it, you think about interstitial nephritis. You will say that, oh, Sri, you are showing me a lot of plasma cells. Okay. See how the disease gets evolved. I should not see red cell cast within the case of interstitial nephritis. Is that right? That is a red flag for you. So you are fishing for something else in this case, and boom. This is an artery which is showing you necrosis. This is a case of necrotizing arthritis. So ANCA we discussed previously in a case of crescentic GN. So a GN can have a lot of interstitial inflammation. ANCA can have a lot of interstitial inflammation. So if you don't sample the lesion part, like if in this case, if I don't sample the artery, I might end up calling this as an interstitial nephritis. If I don't sample the crescent, the glom with the crescent, I might end up calling this as just as a tubular interstitial nephritis. So be aware, if you are suspecting, say, an ANCA in your patient, depending on the clinical features, but you don't sample it, it is still possible for your patient can have an ANCA-associated GN or an arthritis, but we have just not sampled it. Okay. So I think we have seen a lot of good disease entities today, and we have covered almost most of the common diseases which you see in cases of AKI. I wanted to show you a blood vessel and get your feedback. So this is a case, and I wanted to show you a blood vessel. You had seen TMA. Can this present as AKI sometimes? Like what is this? These are the cleft-like spaces within a very bad vessel. Sometimes cholesterol emboli can also present as AKI. So these are very bad vessels, and the blood vessels are showing you cholesterol emboli. So cholesterol emboli can also show you present as AKI sometimes. So that was all I had to present today. So any questions so far? Hope it was
Thanks, Shri. Yeah, that was a wonderful overview. I do have a couple of questions. One is, of course, I hope that after today's presentation, we will all do more biopsies in AKI early on. Before we get to the conference room, I just wanted to ask about, the first case you showed where you said an EM will show minimal change disease. Do you and the special stains, right, for hemoglobin, myoglobin, sometimes that nothing shows up on light microscopy. Do you recommend doing these in all cases of ATI, or do you do that when you have some kind of a suspicion?
So EM we do in all our cases. Like if you give me a biopsy of an elderly patient, like the 70s and 80s, second peak of minimal change disease happens in that age group. So I'm not going to tell you just AKI. I will make sure on the EM I don't see widespread food process effacement, because that is how I'm going to make a diagnosis of minimal change disease. And in a native scenario, I will recommend EM on all the cases, because there are subset of cases you will always end up seeing a surprise on EM. There are many now, the concept of masked concept, right? Masked, the deposits are masked on IF. So suppose you ended up doing only routine IF and that was negative. If you have not done EM, you're never going to pick up those disease entities where the deposits are masked. You end up picking those disease entities because your routine IF was negative, but EM showed you deposits. That is why you went back and did paraffin IF and you ended up unmasking those deposits. Okay, so EM, I will say you have to do in all cases. Regarding stains, myoglobin and hemoglobin, we don't recommend that doing in all cases. In those cases, like I can sign that out as acute tubular injury. But your clinical, that's why you correlate with clinical. So I will dig down deeper into the clinical history, like why did that acute tubular injury started? Did the patient ever had rhabdo or any feature, like did the patient ever had a fall? So my clinical suspicion will be very high. And in a biopsy, you might end up seeing a case where even one pigmented cast is there. You might end up ignoring it. You will say, oh, I am seeing so much of tubular injury. There is sloughing of the lining epithelium. So most likely that is what I'm seeing. So your threshold needs to be low, but you have to correlate that with clinical. So it's a clinical pathological. If you do that on every case, you will end up wasting your resources. So I would say stop, correlate with clinical, and talk to your nephrologist. And that is when you will decide. Because if your nephrologist goes back, hey, I did everything, I just don't find anything in this patient, then I can always go back and do that.
Yeah, sounds good. The conference room.
Yes, hi. Thank you very much for a very wonderful and entertaining talk. I had two questions. One, you showed a couple examples of ATI from probably ischemic and AIN as well. Do you ever venture into saying what you think is the predominant cause of the acute kidney injury when you have, because that's quite a common scenario where you'll have those two diagnoses together? Or is it because of the sampling bias that you can have, you just say, this is what I see, but I can't really say what's the greatest contributing factor here? And the second thing I noticed throughout your whole talk, not once did you say acute tubular necrosis. So is that now the new kind of, we should be going away from saying ATN unless we're actually seeing necrosis in the area of the tubules?
So I would say in most of the cases, you might not be able to find the etiology on the biopsy. So I had shown you the spectrum where I had shown you the etiology, but in many cases in routine practice, you should be aware of those etiologies, but you might not be able to come up with it. So etiology, you have to correlate with clinical, and then I will say in subset of cases, you will be able to find etiology. But if you correlate, you will be. So plain ischemia is the most common, but you might not be able to find etiology unless you see something in the kidney biopsy. And that is a small subset of cases. And regarding the term ATI versus ATN, we should not use the word ATN because ATN is necrosis. Unless I see the necrosis of the lining epithelium, I should not use that. Most of the time, it is acute tubular injury. Till you see the sloughing of the lining epithelium, you should not use the word ATN on the biopsy. I know this phrase has not caught up a lot. Still, people use ATN. But from the pure pathology point of the view, the tubules are injured. Still, they can regenerate. I'm not sure like they will be able to regenerate or not, depending on the extent of injury. Are there stem cells which are still there or not? So you cannot predict those things on the morphology. But necrosis to me is an extensive injury, so much that your lining epithelium has sloughed off. While like if you want, like ischemia is a very clean example to distinguish that. In the earlier phases of ischemia, you are going to see tubular injury only. If the ischemia becomes a lot, then you will start seeing sloughing of the lining epithelium, necrosis. And then again, if I have not reperfused the kidney, you will start seeing the necrosis. And that is how the cortical infarct is going to come. So that's why we don't use the term ATN routinely unless we see necrosis.
Yeah, and again, injury can heal. Necrosis maybe or maybe not. Sort of like the move from acute renal failure to acute kidney injury. David, did you have another question?
No, I just have trouble bringing the hand down. Thank you.
That's okay. If anyone else has any other questions? We have some.
I just have a comment.
Sure.
Swapnil.
Yeah,
First
Janet,
of all,
go ahead.
thank you, Dr. Sharma. I really enjoyed this. I just wanted for the clinician also to make a comment to say the level of tubular injury doesn't always correlate with the renal function. So, sometimes we don't see a lot, but you still have renal dysfunction. So just wanted to make that point.
You are absolutely right. We don't use any gradation systems in acute tubular injury. Like this is grade 1, grade 2, grade 3. But if you talk, I can tell you, hey, this I think is a mild injury mode, but there has not been any studies done. And similarly, AKI in a non-CKD setting is different from an AKI in a CKD setting, because your recovery of an acute tubular injury is not going to be immediate if your background kidney shows a lot of fibrosis. So that also is a different scenario.
Exactly. And you mentioned the sampling bias, right? Which is also important in this context.
Yes.
Peter Magner?
Yeah, I wanted to touch on that sampling bias. And, we've heard about that for years, that you need at least 2 cores or 3 cores or X number of glomeruli to ensure sufficient sample. But I guess the people who do our biopsies, the radiologists, they stab 2 or 3 times. I think they always stab for the lower pole of the left kidney. So we don't know what's happening in the right kidney, and we don't know what's happening in the mid or upper zones. I mean, I guess you are getting stabs that by random chance will be presumably some millimeters or centimeter apart. But is that enough to really get past the problem of sampling bias?
So you raise a great point. So sometimes, just to make fun, if someone asks me, what do you do? I say I specialize in left lower pole of kidney pathology because most of the biases are from the left lower pole. So I don't think we have enough data, but I see radiologists don't like, yes, left lower pole is preferred, but sometimes they don't always prefer left lower pole. They can go mid, upper pole I have not seen, but mid to lower pole they can. But I don't think we have done enough studies to comment on that.
Also,
And I guess my other comment was you had a couple of cases of pyelonephritis, presumably bacterial pyelonephritis. And to me, that's mostly a clinical diagnosis. I mean, somebody should have done a urine culture if there was any suspicion of that. And usually that would be, you'd have a positive culture in urine or blood. And I guess presumably pyelonephritis is segmental, or some pyramids are involved and others not, hence your sampling bias. But most of the rest of the kidney, the reason for the AKI is ATN or ATI. So to me, if you have a diagnosis of ATI and you have a positive urine culture, you have your diagnosis whether you see the neutrophils or not.
Yes, I agree with you completely, because that is, yes, I agree with you. If you see only ATI, if you have positive urine cultures, that is pala, your parenchyma is involved, yeah, and you might not have sampled it, yes.
Jeanette.
Yeah, also I saw that your samples were so thick, like you had so many glomeruli. My cores are so small. The glomeruli often are hanging at the edges. I mean, that's...
So you must be using 18 to 20 gauge, like 20,
Yeah.
don't use 20 gauge.
I know, I wish...
16 is the best one. So we
I
are trying to educate everyone, but still 18 is the predominant one. I ended up choosing cases where I can make the point, but still in our practice, still we have a lot of inadequate samples. Still we end up getting those 20 gauges where the glams are hanging on the side. 18 gauges is most common, but if the patient is obese, 18 gauge is difficult. But 16,
Yes, yeah, and I don't think
16 is good.
And I think they've shown that there is no increased complications when they use a different gauge. So I wish, we could pass that message on.
I agree.
I think there was an early suggestion that 3 passes with an 18 gauge was safer than 1 or 2 with a 16 gauge, but perhaps that's been debunked. But I bet you that's what the radiologists still think.
I agree. Nephrology community always says 16 gauge. Radiologists would always oppose that and will say 18. And recently, some of the radiologists want to do 20 also, but 20 is FNA. That is not even a biopsy. So 18 minimum they should do. Yeah.
Yeah, that's probably something we can review and take back to the radiology community. That's a really good point. So we are just over the hour. Oh, Peter has one last point.
Oh no, I'm just saying thank you.
So thank you, Shri. That was a fantastic overview. We should have you again to go on into the rare causes and not the plain vanilla AKI some other day. Wonderful having you. Thank you.
Thanks a lot. You all have a wonderful day. Bye-bye.